Dean Education, Ravichandran Institute of Higher Education and Research Institute, and convener of NMC Nodal Center, Sarava. We invite Dr. Sarava Sir, Professor of Department of General Surgery, Ravichandran Institute of Higher Education and Research Institute, and co-convener of NMC Nodal Center, SRMC, co-chairman of Undergraduate Curriculum Committee, onto the dais. We invite the facilitators to join Dr. Latha ma'am, Professor of General Surgery, Dr. Ravichandran ma'am, Professor of Pediatrics, Dr. Associate Professor of Pediatrics.
Meet those objectives with your help, and we have planned the session. You have received the schedule with you. How many of you have actually completed this survey? Have you all completed? Are there anybody yet to still complete, and we will give you time as we get ourselves introduced to each of you? Are there still? Can somebody help with the WhatsApp group? It's going to start with knowing you all and in the form of sort of an introduction about yourself. All we want to do, those who have not done the survey can start doing the survey also.
I'm a professor and head of Physiology Department from Hemorrhagic Medical Sciences, just near Ravichandran.
Oh, okay. So from another institution?
Yeah.
I am Srikanth Rao. I am from Streams PCW2 College, working as a professor of surgery.
Professor of Surgery.
Good afternoon, ma'am. I'm Dr. Swati Purma, Professor and Head, Department of Anatomy from Pinnacle Siddhartha Institute of Medical Techniques.
Good afternoon to everyone. I am S. Vidyasagar Madam, General Medicine Assistant Professor in Ashram.
Okay.
Good afternoon, everyone. I'm Dr. Sarava ma'am, Assistant Professor in Pediatrics in Ashram.
Pediatrics.
Good afternoon, I'm Varsha, working as Assistant Professor in the Department of Pediatrics in Ashram.
Masha is our student. Now with you.
Good afternoon, ma'am. I am Dr. Kirti. I am a senior resident in the Department of Pediatrics from Ashram.
Also a lot of pediatric representation.
I am Dr. K. Suhas, Professor in HOD, Department of General Surgery.
Surgery. See, you said that. We have one more surgeon also.
Good afternoon. I am Dr. Kalyan, Associate Professor, Department of Pediatrics, Ashram.
Good afternoon. I am Dr. Raghavra, Assistant Professor, Department of General Medicine.
Good afternoon, everyone. I'm Dr. Latha, final year postgraduate, Department of General Medicine. Good afternoon, everyone. I'm Sarava, final year postgraduate, Department of General Medicine.
Good afternoon, everyone. I am Sai, first year postgraduate, Department of General Medicine, Ashram.
Good afternoon, everyone. I am Dr. Swarup, Junior Resident, First Year PG, General Medicine Department, Ashram.
Good afternoon, everyone. My name is Prasad, first year postgraduate, General Medicine.
Dermatologist, doctor, entrepreneur, and into some works related to medical education. Very happy to be here on this program related to making the doctors into better professionals. Happy to meet so many members from different fields in different domains and seniors into administration also. Best wishes to all and thank you.
Good afternoon, Doctor. I am Dr. Kumar, second year postgraduate from Medical College, Department of Community Medicine.
Good afternoon, everyone. I am Dr. Mohammed, second year postgraduate from Undergraduate College, Department of Community Medicine.
HOD of Pediatrics, Government Medical College, Sarava.
Good afternoon. I am Dr. Srinivas, Associate Professor.
Good afternoon, everyone. I am Dr. Umarani, Professor, Department of Pathology, Ashram Medical College.
Intelligence of circular telling you have to attend their medical education program. I was very excited. You can leave the department and go home. 2 days if you get permission. Then immediately you go and ask your seniors, what did you do in the medical education? They said, no, you do micro teaching. Or the happiness mentoring. So the whole thought was only about doing micro teaching, where you will have other teachers assessing you. Students will also give you feedback. So that's point the whole thing. So that is how we slowly got introduced to medical education. But after attending the course, for the first time we realized every day we are standing before the mirror. We want to look better than the previous day. But when it comes to a professional teacher as we are, that we have to train students. We have never done that. So this micro teaching was the first experience when a mirror was put before us and said, these are the things you did good. I'm not talking about what you did good. But they said, these are the things you did good. You will be very proud. And these are the areas where you have to improve. This is the simple story that I'm narrating is going to be the concept of the next 2 or 3 hours that we are going to work on the session on how to do a clinical round for undergraduates. All of us are suddenly becoming very tired, So much work, multitasking, every day we're sitting with documents. By the time we go for rounds, Varsha must know, we finish rounds and I have to go for the radiology department. I finish rounds and I have to go for the class. That's the hurry which we are in, and forgetting the whole big picture that it is the patient and being with the patient, and our arena of optimal patient care is through optimal training. So we are not working as silos. We are not working separately as a professor. It's all the same. People are caring for them. So the arena of work is not separate. You get educated and then go and see patient. It's happening simultaneously. So we have to structure our training in such a way, ultimately the optimal patient care is given. I'm just going to go through the survey which we have done. And
site teachings are now becoming, with the less number of patients we are having. So it becomes very difficult to actually have students. I don't know, we have a group of students sitting behind. So I think they are also probably losing focus in bedside, learning and bedside teaching. Students now they don't want to touch patients. I think they're all tuned towards their post-graduation needs, and their marrows are not their marrow. The marrow in their phone is actually guiding them. Okay. So how to make it more interesting? So that's why we are all here. So how to make our bedside clinics much more effective and probably utilize whatever little resources we have. How we can enhance our resources and also know today's students, because today's students they are different from what we were. What I was and what you were. The generation gap is there. Everything is changing. So we have to be up to what they are. Okay, so adapt and then make our bedside teaching much more effective, so that learning does happen. We all know for 3 hours they'll be coming with us, they'll be loitering around, and we'll be having half an hour or 45 minutes interaction with them, and the rest of the time they really don't know what they are doing. Okay, so how to make use of this 3 hours in a better way. I know this comes with a lot of effort from our part. I think that is there. So without some amount of effort from our part, this is not going to be easy. So that kind of so this is not going to make teachers' job easier. It is only going to make students learning a little better. Okay, so it's going to be a little difficult only from our part, but we can, with the use of the latest advancements which is happening, like the mobile phones, the AIs, we can use those things. I think it's need of the hour that every faculty learns the AI and all those things, and then use it to our advantage and make learning much better. Okay, so that's the whole idea of this whole thing. I think ma'am has got the result of the survey. I think I'll give it over. Thank you.
That means if I've invested 5 minutes with you, what your action was before that 5 minutes should be different from what you are going to do after that investment of 5 minutes. The reason I am telling investment is now time is the most important thing. Most of the time what happens is we are in the rush OPD, at least structuring is at least now the calendar is good. Somebody, group of students will come, oh today class, you choose the junior most assistant professor, please don't go and take a class. He doesn't know what he has to teach, he is not planned it. Students are also not knowing what has happened, so he only tells what he has to tell and students listen and go away. But we have gone a long way after that, at least the scheduling is happening, we know that academic calendar and whatever the monthly calendar is put, that's the biggest change that has come with the CBME. So we know this particular session, this person has to take and the objectives are also put. And what I would say is the biggest work which has been done by the National Medical Commission is to give the framework which you have. One of the important responsibility if you all ask, how before doing this workshop or even tomorrow when you start a class, the most important thing is to know your framework thoroughly, even before you show it to the students. Unless you know that NMC framework and the UG, the curriculum that is given, which is discipline-wise as well as with integration, how are we even going to plan a session? So you must be thorough with that. Second, this has to be sensitized to the students. You may ask, there's so much given in it, 400 only for pediatrics, another 1,000 general medicine, how are we going to know? The idea is not that. They must know where the link is, they must know to refer it, and when you are planning a lecture class, you are planning, you are saying PowerPoint, the writing objectives like that. Today if I am going to do the round, there must be a lesson. For that, you must know which are those competencies that you are going to teach and the objectives of that particular session. If there is going to be a round which is happening, clinical rounds which is happening, it has to be 10 minutes, you have to structure it. For that, what is to be taught in the 10 minutes has to be looked into the framework that is already published. So which means we have to have the habit of going into the website or having a copy of that volume and always referring before starting a class. It may sound ridiculous. Is this the reason for which 3 people have come or 2 people have come far away to come and tell this to us? The answer is yes. Because that is the lifelong learning and we have not been doing it. When we said we have learned something, our action should change. If our action has not changed, then we have to conduct a workshop even to understand that we have to go and check the book or like a logbook, have that book with us before we plan any teaching learning session. Any encounter which happens with the student is a learning opportunity. That's the next level. That's about the postgraduate. We come to that. But for an undergraduate with 250 students, that's the biggest magnitude that we are having. We have to plan each and every session. So these are the questions. 26 of you have responded. I saw 31 participants, but 26 is a good number. And you see the distribution. Young people we want to teach. What is there? Those older fashioned teachers. It's not so. It's their wisdom and what they experience they share, which add or enhances the conversion of any learning into practice. While we are really talking about learning again and again, you have to convert the learners into those who can apply and actually practice. So these are the basic principles which I am telling. So we can see a lot of, and I am also seeing less than a year, 30%, and the rest constitute around 22%. How often do you engage in bedside teaching with undergraduates? So I am saying 46% few times a week. Then occasionally 30%. So that is where I am concerned. Maybe people don't do, there are from basic sciences may not do a clinical teaching. But can a basic science teacher do a clinical teaching? Yes. When the OPDs, somebody was asking, when we had COVID, we had everybody doing, going and doing ward rounds and everybody taking care of the COVID wards. So we are all first contact physicians already. Then only the specialization. So I am seeing that daily 11.5%. Okay. The next one, which teaching method do you commonly follow during bedside teaching? History taking and clinical examination, case discussion. The top is history taking clinical examination that you are doing, demonstrating clinical skills, bedside questions, reflections and others. Good. So good number of you. I'm going to stay a little bit more on this part of the survey. When we are talking about all of this, how many of you are actually talking about taking the undergraduate with you, 4 or 5 of them in the round? Or are you talking about they're coming for a class, you give the case and you go for the round and then somebody faces. I'm asking a very specific questions. I call the one as A and B. How are you doing the undergraduate teaching? How many times are we taking the undergraduates? We are doing rounds with the postgraduates. How are we? Are we taking the undergraduates with us for a round? Or we are in the OPD, we are in the round, there is a room, allocate a case and say we give you 40 minutes. Please do the examination, history and examination, and I will come for the presentation. Let's be honest, I am talking about myself also, it's not only you. How many of you have done A? Let us, yes? So 2 hands, B? A and B? No, let's be honest, A or B? B, both? Both. We are talking about 250 students. That means our structured teaching is same for every batch of students.
Depends on the cases that are present and the scope of teaching, scope of demonstration of skills.
Okay, okay. But then is it that, again I am repeating, that you are taking every batch of undergraduate students for a clinical round along with you when you are making a round? Or you are saying some registrar allocates a case and the cases and the students are in a room and they are doing the history taking exam, they are doing, and you finish the rounds and you go there for a class. Yeah? So this is only, I'm only putting a mirror, I'm a mirror here. To myself, I'm a mirror. So to what we are doing, that in such situations, if our objective of taking a particular clinical round is saying, at the end of the session, the student should be able to elicit the history. So, have you observed them eliciting? Have you given opportunity for all the 5 students entering minimum number to elicit a history? And have you given a feedback telling them that you have taken or eliciting a history correctly or not correctly, or you could do better? So CPME addresses that. It's not about one student performing a particular skill excellently and getting a distinction, but every student performing it at a minimum level to the standards that we ourselves have set. Okay, so coming to this history taking, the question probably I should have added, and the reason I qualified it because it is individually telling that we are history and physical examination, but we have not said how we are doing it. We have agreed that case discussions are happening, that's most of the time. We have agreed that demonstration is happening, but we don't know, we are asking each and every student to demonstrate it. And bedside, Viva and questions, I think that is reasonably, when it comes to questioning, most of the time we have to ask questions, that is being done. So the next is, how do you ensure active student participation during bedside teaching? Ask questions, assign roles. I can see 12%, 46.2%. That is 12 of you have said assign roles and tasks. Allow hands-on practice and use checklists or logs. So when we say assign roles, can somebody help me understand that better? Assigning roles. First of all, I'm not judgmental. I'm one among you. I'm very well the more number of mistakes that what actually we are collectively now looking into correcting ourselves. So, just when we say assigning roles, what do we mean by that? Okay, so at least so far we have assigned it. One student is the presenter. We are assigned. The rest of them we have not actually assigned. They have assumed the role of an observer. If they have said she will be the presenter, but each of you will be given a patient to take a history, and we are testing your interviewing skills. So there is a role for all of them, but one becomes a presenter. You understand? So now it is the same scenario. Still you have to have case discussion. Still you are going to go ask them to present. But then we have to give a feedback to each and every student that they have elicited a history and they are presented. So two actions. They have to elicit, they have to present. So but we have assigned it to one student and the rest. Okay, so that's the challenge. We will come to it. I think sir has brought it out. One, assigning from our part, we have not told what to do. We have to tell them every step. The other thing, in spite of us telling, people still do one. We'll come to that, how we will set that line. If we had given a checklist of what they should ask, and the student asked them to say, please observe that girl taking an history and use a checklist to say what she did correctly, and then they'll be very happy, they find fault with that girl. So, but then we are involving them. So there is an observation, there is an actual performing, and there is a reflection of what they did. So these are the various terminologies that I'm actually introducing also. So it's nice to know still clinical teachers are struggling to see. It's not about we are not doing it. We are struggling to get skills and also understanding the ethical dilemmas. We don't need a separate diagram. In one clinical round, could we not do that? Yes. So consciously we have to integrate it into this. So the next one, CBME alignment. This is another thing. Again, I already presented it. I can see that more than 50% are saying we are aware of the CBME alignment. But to be honest, if you are not verifying it every day and using that to see which of it I am going to teach, you have not done the job 100%. So the most important lifelong learning is for us as teachers is to go and refer the competencies that are given, whether it's a postgraduate or an undergraduate, every day at least to have a look at it before you are structuring your class. Which CBME competencies do you try to address during bedside teaching? I think almost everybody is agreed that it is not only the clinical skills, but we have also added reasoning, professionalism, attitude, empathy, everything together. I'm going to talk a little bit more about the critical reasoning and critical thinking. Many times the terminologies are sounding so scary, and we are also not too clear what we are supposed to do. We'll talk about it more. Do you use any CBME tools during bedside teaching? I think logbook, fantastic, I'm so glad. One of the very efficient tool which is so underutilized is our logbook. The last day before the exam, all the pages will rush, my logbook, please sign it off. The purpose of the logbook is gone, it's only coming after 3 years of there. What Varsha, she's smiling. What Varsha? UGs, that's what I'm coming to. PGs, at least we are closely watching. UGs, same last minute. So the logbook, we are moving away from a summative assessment to a day-to-day evaluation and a feedback for improvement. This is called assessment for learning. Every day we have to give a feedback. Today morning, that's what I was discussing with Saran today. He was telling me we were having breakfast and I was describing how coffee we make at home. And in my house, that coffee making is a big thing. You have to do it perfectly, otherwise I'm gone. Even boiling milk, and it will be verified. The boiling milk, the trim which is there, we should reduce by 0.5 centimeters to make that, to get it stamped as the correctly boiled milk for that right kind of coffee. And if I don't do it, somebody will come and say, oh, you're not boiled, please do it again. And how much of powder in that filter? 1 water, and we should take a spoon, not use that pressure thing, and we should not press it too much Then you add boiling water, and the water should keep on boiling. It should not switch off the stove. You take a spoon or something, and little by little you have to drop, and it will be heard by small drops falling. That should be heard. Then only you are done by decoction. So I keep telling if everything is listening, because my father-in-law is in the hall listening to that sound. If he doesn't hear that correct drop in that correct thing, then my coffee is not good. You know, too much of Sarava is laughing. So he said, please madam, tell this today in the class so people will know how important. We are dealing with lives and we are dealing with that's a skill.
The students are learning. Every small step is
important. So we have to make effort, sit with them, be conscious of what we want to teach. Don't teach too much. It's not needed. In one clinical round, you're going to go through that exercise also. You decide what you want them to learn and concentrate on it. Too much also, no, they won't learn. Again, Russia is looking at me. No, multiple. Sorry, I'm going to pull you more because she's been my student. You know, in the round, suddenly they will be looking somewhere. The phone will ring. Madam, 1 minute, madam. Somebody is calling me, they go out. A patient is called, I'm going. Whether they really want the patient to call them and go away from the class, or is that they're getting disturbed. I'm not sure. So that's the situation all of us have gone through also. But these are all the learning opportunities. It does happen. We are getting interrupted in between. My net did not work. Suddenly I forgot the password. So in meantime, someone was engaging you all. I called my office and I got the password. But this is not known. But the intention is this survey is very important for the next 1 or 1.5 hours that you're going to spend on this. How confident are you in integrating? I'm so glad. Somewhat confident, you have honestly accepted. This somewhat confidence has to become confident. The reason it is somewhat still is because, I'll ask you a question, how many of you have even visited that UG, NMC competencies? How many of you honestly tell me? Yes? How many of you are looking at it weekly once? How many of you are looking at it monthly once? Yes, whenever you want to plan a theory class, not for clinical, theory class alone you have seen now, very good. But the point is it has to be in your mind. It has to be saved in your iPad. Every time it has to be given to your students and reminded, please have a look at it. If they are coming to pediatrics, I will say it's a 400 madam. I said don't worry about that 400, I only should learn. Students are here?
Yes.
So we have undergraduate students? Undergraduate, UGs? How many UGs? Those, they're so silent now. I didn't know that they were there. How many of you have so now you will do that homework. Please see NMC UG curriculum. Just go and see. I want you to do that now. I'll come back to you. Yes, sir, we are going to do learner doctor. But only a part of the learner doctor, we are going to do only clinical. So what is this learner doctor? Anybody? Misinterpreting it. Yes, sir. Misinterpreting, number 1. Okay. Absolutely correct. So misinterpretation, those are the challenges. A learner doctor, we say many people are actually telling I am not aware of the method. First of all, for any learning is to accept that I don't know. I am very happy with your guys. So what is this learner doctor and what is this particular workshop concentrating on? The learner doctor methods. You want to explain?
Because I am involved in learner doctor method in the institute, and I think it's very clear from the curriculum book that how a learner doctor method has to be done. So it is like a longitudinal follow-up of a patient right from the time the patient gets admitted to the time they get discharged, and it need not be on an exam case. See, we all get the idea that it has to be an exam case. It need not be an exam case. Sir? Like?
Admission to discharge.
Yes, sir.
Student has to follow this patient.
Yes, sir.
But practically they will be with us from 9 to 12. Even if you ask them to come after 4 p.m. or 3 p.m., they are not coming.
Yes.
So sometimes they come, the patient will get discharged.
Yes, sir.
So this is the problem.
Yes, sir, but still, the patient is going to be there at least 4-5 days in the ward. During that time, they can be involved in that. Not that at the time of admission they need to be there.
When they come, they will go for investigations. Patient will not be available. These are the problems. So when asked, yesterday patient was admitted, today and go follow. Get the investigation. They don't go to the area.
It's just one patient which they have to follow up. They should find the time. They should probably come back.
One student, one patient.
Yes, sir.
Like that, complete student has to be attached.
Yes, sir.
They have to follow from admission to discharge.
Yes, sir.
Suppose that patient incompletely investigated, again he will get admitted. They have to follow up that also.
So no need, sir. Not necessary. It's not that they have been bound to that patient. It is only they just instead of having a patient at one time encounter with the patient is what the students are having. That is, when they are taking a case, they are briefly they talk to the patient. It's not like that. Right from the admission, they follow up the patient. What are the process which is involved in a patient care? They follow it every day, like the investigation which are done. If they are going for a surgery, even the communication part, everything is happening with this one particular interaction. It is not a replacement for the traditional methodology. That is why what we always do.
They are supposed to record.
Sir, can I simplify?
Yes, sir.
Actually, what we will do is students will come and take a case and they will present to the faculty. So that 2.5 hours are around for 30 minutes. It will go on like that. This one hardly it will take 15 minutes or 20 minutes in a day. They will come at 10 o'clock. They will see that particular patient, whatever investigations, whatever history, whatever examination, and every day they will follow that. They will follow the symptoms, they will follow the signs, they will follow the investigation. Hardly it will take 15 minutes for one patient. That means that by the end of the week, they will familiarize with the particular disease. This is the actual natural pattern of learning.
Exactly.
And most of the learner of the method is observation. While case presentation, specific skills that we are teaching, here also they are learning, but it is more of they participate in the regular working of the ER, they participate in accompanying the patient to the ward, admission process, admitted, follow the case like we are doing as consultants to understand the concept of longitudinal follow-up of a patient. Otherwise, they say just presenting one case, tomorrow this case coming or not, they don't know. So what happens at discharge or somebody is being made? And for the challenge which he has said, none of the students are coming. I'm going back to my coffee. If that day nobody has told me that I have to boil milk by 0.5 centimeters go down, if nobody has told me that I have to cover the filter only with 1/3 coffee powder, if nobody has observed and told me this is the way you have to lightly tap the top surface of the powder and add a boiling water without switching it off little by little, I wouldn't have learned it. That is where the feedback comes. And the feedback need not be always in a room, call them one by one. It can be done at observation. So if a learner doctor is with 5 members, is with one doctor or a mentor, he is there globally, then he comes back for the rounds. He goes to these students will go for a follow-up. And when you go for the round, you call them. What did you find? What do you think is happening in this patient? And ask them to demonstrate certain skills. And you say, what did you document? What does this mean? Ask questions. Then they ask them to reflect. They say in these reflections, this is correct. You made this diagnosis, this is wrong. So why this is wrong? Give the reasoning. And ask them to demonstrate. If they are not demonstrating correctly, you correct them. So this is about a learner doctor, but this is for any clinical doctor. So you have to give a feedback. If there is a methodology, there must be an assessment. If there is an assessment, that indicates the outcome of the performance of the students. If there is a performance, you are ready to be So that is the complete cycle. Now the other challenge, where we are doing so much work, I am in the ER, I am doing this documentation, inspection is coming, dean office is calling, I have to do face ID, suddenly I have to do biometric. How can I concentrate? We are going back to it. Structuring, planning, pre-planning, pre-planning is what will help you in this situation of delivering a clinical teaching when it comes to ward rounds or any patient encounter. Okay. So I think it's all the same. The reason we spend more time in learned doctor method, even for us there was a confusion. Are we going to do learned doctor method when this topic came to us? Then we clarified, no, we are not doing learned doctor method, but we are showing that difference. We are going to concentrate even to a smaller aspect of this whole learned doctor, only teaching in the clinical rounds. I am so glad the undergraduates are engaged. I can see all their heads into the mobile for a good reason. And all this while they were all looking very, vacant, but now they are involved. So engaging students in anything is important. So did you visit that website? So what did you see? I can see all of them shaking their head vigorously. So what did you see? So that question I'm going to ask. Anybody can answer? Okay. So I've just seen only the link.
Topic of the discussion and whether it is lecture or self-group learning or integrated classes.
So you're seeing the actual structure. You see how much your teachers are learning for your sake. You know all that was done by teachers? Do you know that? 40,000 teachers have sat together and done that. So you should read, no. Little bit thankful. So what class did you have today morning? All belong to the same department or different variants postings?
Theory classes are same.
Theory classes are same. Now another homework. Go and search in that framework what topic was taught to you today and what were the objectives and whether their lecture it is telling and see whether your teachers have done correctly. Goals.
Competency number.
Competency number.
Please tell the competency number.
Okay. So these are so what are the challenges? Large student batches. We must consciously break them into smaller batches. How and why? That's why departmental meeting. Every day we don't do any curriculum development alone. It is not possible. You have to sit as a group and plan for next 6 months. You should beyond, 6 months from now you should start planning now. That's why we are now uploading the calendar. Clinical teaching should also be planned. If we are getting 6th semester, we should be thorough with what are all the clinical bedside teaching that we should do, what we should do as a case presentation. That kind of an information should be available and you should have a lesson plan for every session that you do. I'm sure students, general medicine, who I saw somebody from general medicine. General medicine? Okay, so 2 of you from general medicine. So the registrar is the only power person sitting and doing the calendar, or all of you sit together and do the calendar. We discuss and you do it. General medicine does it. That's why I asked you. I didn't ask surgery. So I asked general medicine. And for some time I'm spared many at least. Because they do very micro level, they will do their lesson plan. Okay, so you do a group discussion and you put a plan. Make sure, and then it goes to the unit, and unit has a plan. Am I right? Every unit the students are distributed, and the unit also puts a plan and gives to the students. Make sure that every individual who is responsible for a class, is it going by name or generally you are giving it as a professor name? By name. If you are doing that, let the lesson plan be told. And let that be told to the students also. So that's how you handle large student batches. Time constraint, lack of trained faculty, patient-related issues. Patient-related issues will come up. Even if there is an emergency, use it as a teaching or an observing. You just say, I'm going to attend to an emergency. You see what the team is doing, all of you observe. Done, they will be involved. See all of them, how they are working now. They are given them. See, they are not even, they are all engrossed in finding out how the teachers were learning. See, they are all engaged. Okay. What support and training would help you faculty development. That's why we are having this workshop. Very true. We are lifelong learners. For all the students to learn, we'll keep on learning and we'll always be outdated. Because they are more into technology, and for us technology is like a monster. They are into, but then we can't be doing away with technology. That's going to be more of it probably tomorrow and in other discussions. Yes. Templates for assessment. The other easy way is to give a checklist. See, our students are very brilliant. They are not depending upon a lecture class to learn. They are coming here only for attendance. Yes or no? No. Tell me truly, you are coming to class only for attendance. No. No. Honestly, they are answering. All of you put up hand. Those who are coming to class to learn or for attendance? To learn? Please, you have heard it. You have heard it now. You have all heard it. They are not coming for attendance. They are coming to learn. So from tomorrow onwards, every class will have a test and they will take it. Okay? So now we are scared. So peer observation. Today I listened to something which I was very thrilled about when we had a discussion in the principal's office. You have a practice of having two faculty in the lecture class, am I right? Somebody takes a lecture, there's also another faculty. Are you having it? They are planning it. So peer observation. Okay. So I leave it. Right. See, peer observation, again, time constraint, more than one faculty involved. You can think about your own lecture capturing systems, where you can review your own classes and see how impactful it was based on a checklist. And I think Varsha knows pedagogy, how it is done for you. You can explain? And later, we'll do it later. So what are the expectations from the workshop? Helping to teach better, ease in teaching, learning experiences, to clear about CBME, teaching skills, including teaching. Okay. So everybody wants to become better. But in the context of bedside clinical teaching. I just add on, we're going to focus on it. Okay. So any clarification so far? Any questions? So this is a very beautiful survey. I'm very thankful to each one of you. You've been very honest in answering. This kind of surveys are the one which actually gives us the expectation of what we want to learn, and it also gives us who are conducting the workshop how we have to tweak the workshop to your needs. Working as a unit to take care of the patient. Ultimately, if these are not aligned correctly, our patient care will suffer. Do you agree or not? Many times what we are telling, don't ask that PG to go and see, you only go and see. Why are we telling that? If there is a postgraduate who has to see a patient, has to make a record in the document, he has to do it because that's the learner responsibility. They can't run away. If they are not doing it, that's when the teacher's responsibility to say why he is not doing it and how we can make him do it. It's not accepting that he won't do. We have to make him do that. So there are general principles in teaching the clinical grounds. So the main objectives of our rounds, this is specific for undergraduates, is one, to improve the history taking or the interviewing skills. When students are there and say, please go and interact with any patient. If you have a 12th standard student and we have an intern who's doing there, the 12th standard student can also interact with the patient. You can also have an intern interacting with the patient, but what is the difference? Advanced standard student is excited. Yo pavo, mother something la, enna something a koli biryani something la. But I'm telling in Tamil, is it okay? That's the level of emotional they have. But when it's an intern, if I speak in Tamil, are you understanding? No. Okay. It's okay. Why you are having abdominal pain? Where is the pain? Is it associated with fever, vomiting? How are your stools, bowel movements? You see the difference. So, this improving history taking is again towards solving the problem of an abdominal pain for that patient. Always when I say, if there is a plumber, the plumber has to fix the tap. Whatever ways he does, he has to fix the tap. If the fixing of the tap is not done, then the plumber is ineffective. Same like that, we are in charge of taking care of the structure and functional normality of any patients. When we call patients that they are not having a normal structure or a normal function. But we have to convert them into a normal being. That is our role. When we use, for which we have to use the appropriate skills of finding out the reason. If it is a structural abnormality, we use surgical pathways to correct it. And if there is a functional abnormality, we are using pharmacophysiological pathways to correct it. This is the basic principle. This I quote Professor Tom Arets from Harvard Medical School, with whom we were associated with more than 10 years, who said the most simple way of understanding medicine. And these are his words. So it looks very simple, no? It is that simple only if you are committed to talking to patients in the way we want to. And the way we have to solve the problem. So improve history taking, physical examination. We are skillful is because we have certain knowledge when we do a physical examination to find out, just like a plumber, why a tap is leaking, to find out why there is an abdominal pain in that patient or the problem that has. So we have to do a structured physical examination. So it has to be perfect. It cannot be any other way. If you ask today, again coming back to your undergraduates, interns, they are still engrossed in looking. Have you looked into it? Have you seen? So is it there? Today's class it is there. So how much your teacher should have worked, no? 1 year, 2 years ago to design all that and then come for the class. Should you not appreciate them and give a big clap? Okay. Now, if I ask each one of you to do an abdominal examination, can I ask you to demonstrate now in a standardized patient? Everybody is putting their hands up. Okay. The reason I am telling is, when we do a physical examination, it cannot be different for different people. Even if there are 250 people, they have to do it perfectly. So the clinical rounds should insist on that. What we will do, when you are taking round, we talk about Wi-Fi things, the PG will discuss, management will go away. But are we consciously describing to them or demonstrating to them how a physical examination? You do it in case discussion. I agree. But I am talking about every individual before they go and actually do it. This is how you can engage when you don't have enough number of patients or you are more busy with other patients. Develop clinical reasoning. I'm going to talk more about this clinical reasoning and diagnostic skills. Enhance communication that we have been talking about. Demonstrate professional behavior. What is this professional behavior? You know, we always love to have a teacher in those traditional days. One teacher used to be attracted towards his class, the way he teaches, we want to attend his class, and we look at his behavior, the way he is talking, the way he is addressing, the way he is directing, and how compassionate he is with the patient. Those are the things which we, as called role modeling, that we have adopted. But now we are saying it's not enough you have one teacher like that. You must have all your students to have a professional behavior, and that's why we are having APMEDUCON. So APMEDUCON is not a parallel thing. Nothing will be there. Am I correct, Professor? So it is not about, it's about the application of why we are writing a patient. That documentation has to happen in the case record is because that is only the evidence of what treatment you have made, and that is what is going to legally support you also. So there is a responsibility there. And finally, discuss management plan and ethical dilemmas. So these are the reasons or objectives of our outcomes. So general principles. Ma'am, it is not telling ma'am, every day we are taking notes, why are you going on telling all of this? Reinforcement is the way by which we structure ourselves. 100% I am sure for at least the next 1 week, you will start structuring your workouts because you have attended this. Sustenance comes. That will come if you are consciously in your own department, you start writing a lesson plan or structuring and whatever. So coming to clinical reasoning, many of them will ask what is clinical reasoning? It's simple. Gathering information data from the patient and using that data and applying it to understand what could be the diagnosis and also using some of the patient information including their laboratory to make a clinical diagnosis and then formulating a treatment. This is clinical reasoning. If you add a little bit more to this, when you use judgment based on analysis, data and evidences to the whole of this in the management of the patient, that becomes critical thinking. It is a higher order where more of data is used, more of evidence is used, and you are going at a higher level. So clinical reasoning using patient data to make a diagnosis, and critical thinking is using evidences or other gathering, other analyzing the data and coming to an interpretation or a judgment based on the analysis and the evidences that are there is critical thinking. We are going to go stepwise. You are going to actually do this with the worksheet now. So first you have to have clear objectives. These objectives are defined from the competencies worksheet framework that you have. You have to make them, break them into objectives. You may ask, what is a competency? Have you done the objectives for all the competencies in your departments? Have you broken all the competencies into objectives? So pick up those 1 or 2 specific objectives. These are the ones that you are going to accomplish at the end of that month. At the end of this one clinical round, the student should be able to interview a patient, should be able to demonstrate a physical finding, should be able to communicate, or should be able to arrive at a diagnosis. So those are the defined. So the critical or clear objectives. You have the lesson plan in PCME, we have the template given. Use that even when you are doing a clinical round teaching. Then select the appropriate patient. This is the most important thing which we forget to do. Normally we have the list of cases that are there in our unit or under our unit. So before going to the ward round, you see that list of 10 patients. I am a pediatrician, so I am using those cases. One will say acute febrile illness, B is associated LRI, acute watery diarrhea, pneumonia, delayed development, global developmental delay with something, child with Takayasu disease. I am having the real list here. A congenital heart disease with infective endocarditis. In that list, today's objective is to demonstrate physical findings of an infective endocarditis. If you want to see, if you keep that as an objective, select that case. Then you say, out of the 10 cases, you have to call all of them for what we call it as a pre-round huddle. It's called pre-round huddle and assign groups. There will be a PG. There will be an undergraduate 3 of 4 students, and you will say you are assigned to this bed, this bed, this bed, this bed. Your role will be observing. When it is a PG who's doing, your role will be a presenter survey, and your role will be explaining to the patient. Like that, you have to give them the roles for the assigned from the selected 10 out of 10, only 4 you are going to teach. The rest you will do your own with your PGs, but you are going to concentrate when it comes the 4 undergraduates who are there in the hall. So you have to prepare the learners and you have to tell them, today you are going to take a history for immunization. Give them the checklist. These are the questions that you have to ask them. If you can't sit and explain to them, prepare a checklist and give it to them. And let them use the checklist for doing the interview. The reason I am telling this is, how can we accomplish that? You can. You start doing it for 1 session. Over a period of time, you will find that you have accumulated and documented and keep it as a lesson plan. You can give it to anybody and anybody can use it. And the last is ensure effective communication and feedback. When they have done it, they have taken an effective history immunization and presented. Immediately you say, you did But make sure before that you prepare the patient also. You have to tell, we are going to come for round. This doctor is so and so, is going to ask you a certain question. I am your consultant. I am your consultant. Please answer and give him the information. Once he is done with it, move him away from the patient. Don't do any discussion which involves large medical jargon in front of the patient. But you can take them aside and say, let's discuss this now. What did you ask? I observed you asking. You can't say elicited history and you can't move away. You have to wait and watch what questions he's asked and what he's telling back. Reassure the patients and telling, reassure, move away from the patient and then go and say, you did this correctly. You observed, you asked for the immunization card. You looked for the BCG card. You asked for the last vaccine. But you did not complete the history. What is missed, or you did not see the BCG card. This kind of a feedback should be done. So next time when you do it, what would you do? That is completion. Because he will say in this way will go away. That much of objective structuring. And you don't need to take big long classes. You can take short ones but address the different ones at different time. So that is the teaching in the walk. So a structured approach with a pre-round huddle, clear goals and focused discussion points will enhance the learning experience. So one of the most important things, as I said, curricular alignment. When we are talking about a particular one objective that you are going to observe, it should relate it or you should be able to align it with the framework that you are having, which means every day the teacher should have looking at those frameworks. Over a period of 2 years, you should be thorough with what all is in there. There might be changes, they can remove, add a few more, but you must be thorough. And time management. So again, patient selection is important. It depends upon the relevance, the diversity mix of cases, because they are going to be first contact physician. Ideal will be to do a round where all kinds of patients are there in an ER. I'm just saying, or in an OPD. It's not about having only pediatric posting, only pediatric. You should be able to see a pediatric patient, antenatal mother, just as they are coming into your practice if you are a general doctor. Anybody can come. Anybody between 0 to any older age will walk into a general doctor. So that kind of an atmosphere, if you are able to give, that will be the best. But that is not possible because they are coming to you. But give them that experience. If it is 0 to 18, we are saying you are being able to show them, and you should be able to a toddler or somebody who is 18 years old. All kind of patients, but you should do the selection for that. You can't load everything together on one day. You have to select the cases. As I said, pre-round reading, the same example of immunization I am telling. The previous day for a class they are coming, you should provide them with all the checklists, the sample immunization card, and what questions that they want to ask in the history taking may be given earlier. You can share it. Case presentation and specific roles that I have already said. Who will be the presenter, who will be the observer, who will be the demonstrator, and who will be summarizing the whole thing. All these roles have to be assigned. So this all I have already said, and finally summarizing the key points. There are certain tools which Sarava is going to talk about, which will be, it looks very vague now, I'm structuring, but there are certain tools which can be used for teaching and learning in a bedside clinic and doing an assessment also, which will be talking about it, which you can apply. Something like an OMP or a SNAPS model can be applied when we are doing actually the clinical work. I have given you the general principles, but what are those methods which are incorporating these principles he will be talking about. So debriefing, at the end of it, give at least 10 minutes for a debrief, and all of them assemble together and say what learning happened and reflect on it, and that is the time you ask them to fill the logbook also. So if the learning is not documented, it is not getting interrupted also. So how many of you are filling the logbooks immediately after your classroom sessions, or when are you filling it? Logbooks? Immediately after your class, you are filling it? And you are getting it signed, feedback is given, that you did well, is given, excellent. So if you are doing that, a very major thing. Are you telling? Everybody is laughing also, some of them. Are you doing it? So they are very protective of the teachers, I saw that. Good. I'm not, don't